The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Role of Selectins and Adhesion in the Pathophysiology of Acute Vaso-occlusive Crisis in Sickle Cell Disease. I'm Andy James, and I'm the president of the Foundation for Women and Girls with Blood Disorders. I'm a professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine at Duke University, and I'm a consulting professor of medicine, Division of Hematology. Next slide. For those of you who may not be familiar with the Foundation for Women and Girls with Blood Disorders, our mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Our faculty today is Marilyn Tellen, and I will be the moderator and commentator. Dr. Tellen, our presenter today, is the Wellcome Professor of Medicine at Duke University. Dr. Tellen is renowned for her pioneering work in sickle cell disease and red cell membranes. She is a former division director of hematology at Duke. Her current research explores the role of red cell adhesion molecules in sickle cell disease through both experimental science as well as genetic and clinical translational research in sickle cell disease and transfusion medicine. Next slide. So we have the following disclosures. Next slide. We have a few housekeeping details. To ensure the best sound quality during the webinar, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with the faculty at the end of the webinar. You can submit your questions during the webinar or after the presentation portion of the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen, and we will address them during the Q&A session at the end of today's presentation. Next slide. Before we begin, we have a few questions for the audience. The first question is a quick poll to see how many people are joining us today, along with others. Please take a moment to answer the question on your screen. Okay, thank you very much. It looks like about half of you are watching as individuals and half of you are accompanied by someone else. We have the following pre-test questions. The first question, please take a moment to look at the question on your screen and respond. Okay, I think we have everyone having responded. Thank you very much. And the second question, let's answer this question. Are there any other responses? Okay, I think we can move on. Next slide. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we are recording the program and it will be archived on our website. I would now like to turn the program over to Dr. Tellen.
Thank you, and thank you for inviting me to present this talk today. Next slide. I'm going to be talking a little bit about the pathogenesis of sickle cell disease in order to put in context the drug development that I'm going to spend most of the time talking about. So even though we all know that hemoglobin is only expressed in red cells, when sickle hemoglobin is expressed in the red cell, we see a lot of abnormalities of the red cell. We know that there's hemoglobin polymer formation, which causes the formation of sickled red cells under low oxygen tension. But a lot of other things are wrong with the red cell too, and these include that the red cells get dehydrated, that they don't regulate their lipid sidedness, and so they expose phosphatidylserine on the surface, which is not normal, that there is increased oxidative damage of cell membrane proteins and probably cytoplasmic proteins as well. Sickle red cells have abnormal content of both nitric oxide and ATP, both of which help regulate vascular tone, and sickle red cells don't deliver these substances well either. And finally, most pertinent to today, these sickle red cells have abnormal adhesive properties, meaning that they stick to other cells much more than do normal cells, and that's true even if they're not actually sickled, even if they're still in a sort of normal conformation. In addition, we've learned that these adhesive properties are due in large part to the fact that sickle red cells have abnormal intracellular signaling and are thereby capable through their adhesion molecules to accomplish abnormal intercellular signaling. Next slide. So this is a schematic of kind of all the things that go wrong with sickle red cells. It's clearly a very brief schematic. On the left, you see that you get the polymerization or gelation of hemoglobin S. That leads to red cell signaling, and that can lead to hemolysis. And in those processes, you also see dehydration. On the top right, you see adhesive interactions, and I'm going to go into them more on the following slide. And then to the right, you see that sickle red cells also engender a number of inflammatory stimuli. They can directly activate white cells. They can also directly activate endothelial cells and platelets. In addition, that leads to production of pro-inflammatory cytokines, many of which are increased in sickle cell disease, some in steady state, some in vaso-occlusion. And they induce overexpression and activation of adhesion molecules on other cells, including the endothelial cells, the platelets, and the leukocytes. Finally, sickle red cells activate coagulation, at least in part through exposure of the phosphatidylserine I mentioned during the previous slide. Next slide. So this slide illustrates the many different kinds of, next slide. I don't see it yet. Thank you. This illustrates the different kinds of adhesive interactions that you can see in sickle cell disease. And this can be seen in animal models as well as in vitro. So A shows that the sickle red cells, whether they're sickled or not, can adhere to endothelial cells, which can induce endothelial activation. In B, you see a red cell circulating, interacting with white cells. In C, you see white cells that are adherent to the endothelium, largely probably induced by cytokines, but also by red cells. And once those white cells adhere to the endothelium, they capture red cells that are passing by. And they also form multicellular aggregates in the circulation, as shown also in this slide. And then in D, you see that this multicellular aggregate can include red cells, it can include white cells, and it can include platelets, or the little blue things. And they can exist in the circulation or adherent to the endothelial cells. But ultimately, if the aggregates get large enough and the vessels are small enough, you get vaso-occlusion. And in animal models, most vaso-occlusion occurs in post-capillary venules, which are small but not clearly as small as capillaries. Next slide. So there are a lot of different pathways by which the red cells adhere to endothelial cells. And this slide shows all the pathways for which there is at least some in vitro evidence showing that the molecules indicated participate in adherent events. So there's a number of adhesion molecules on red cells. As you can see, all the things that are listed in the red cell, and they interact with a variety of molecules, some of which are expressed by the endothelial cells, shown as pink cells, and some of which are actually extracellular matrix proteins that are expressed by mostly the subendothelial matrix. But when endothelial cells get activated, they retract and expose that subendothelial matrix. In addition, laminin or LAM, thrombospondin, which is TSP, and fibronectin, FBN, are also circulating molecules, and in general, their concentration is increased in sickle cell disease. Next slide. So there's a fair amount of evidence, as I've suggested, that white blood cells are activated in sickle cell disease. You can measure that by flow cytometry. You can see multicellular aggregate formation, which you can isolate from whole blood, as well as form in vitro. And when you expose animals to cytokines such as TNF, but including others, you can actually see that the white cells adhere to the endothelial cells and the red cells adhere to the white cells. Depending on the cytokine, the red cells also adhere directly to the endothelium. And as I mentioned, the cytokine levels are generally, pro-inflammatory cytokines are increased in sickle cell disease and go up further during vaso-occlusion. Next slide. And here is another slide showing you that there are multiple interaction points, both between red cells and white cells, and then between white cells and endothelium. But when you get to the white cell endothelium interaction, there are primarily two points of interaction, both being mediated by selectins, the P-selectin and the E-selectin. So I've shown you these slides just because there are a lot of points at which one could potentially interfere with adhesion, but for the moment, it is the selectins which have garnered the most attention from the pharmaceutical industry. Next slide. And this is just to amplify what I just said, that the light blue boxes here really represent agents which have either been tried in people or at minimum in animals in order to stop some of the pathophysiologic processes that occur in sickle cell disease, as I had shown you before. So you can see that hydroxyurea is included, antioxidants, anticoagulants, anti-inflammatory agents. There have been, and antiplatelet agents, and there have been recent clinical trials, early phase clinical trials, really on all of these. And of course, only some of them have gotten beyond the very early stage. Next slide. So I think I've explained the rationale for targeting adhesion pathways in a therapeutic manner. And the challenge has really been where to aim the therapy, because lots of different molecular interactions have been identified. Next slide. The drugs and the trials I'm going to talk about today are represented in this slide, and it really involves 3 drugs. Rivipansel, which was originally called GMI 1070, Cell-G1, which is now called Crizanlizumab, and the third is Sevuparin. And these are 3 very different molecules. So Rivipansel is actually a small carbohydrate molecule. It actually binds and blocks all selectins, although it has much higher affinity for E-selectin. And it has been been published. The phase 1 and phase 2 trials have been published, and it is now toward the end of a phase 3 study. They probably have less than 50 patients out of 300 or so left to accrue. So I think it's fair to expect that they're going to be finished probably by summer. Crizanlizumab is a humanized monoclonal antibody that blocks P-selectin, has really no activity against E-selectin, and it has completed a phase 2 outpatient study. I will point out at this moment, and talk about it again later, that the Rivipansel molecule, which is intravenous and fairly short-lived, has been used or studied for the treatment of vaso-occlusion, whereas the monoclonal antibody, which is also intravenous but more long-lived, has been studied to date for prevention of VOC with chronic therapy. The last molecule is Sevuparin, and it is actually a derivative of low molecular weight heparin. It does not have the portion of low molecular weight heparin that causes anticoagulation, and so it has just about no measurable anticoagulation activity, but it is a pretty good blocker of P-selectin, and actually is as is heparin itself, a molecule which interacts with and blocks several other proteins, including fibronectin, which I had mentioned in a previous slide. And it just recently completed a phase 2 study of using this molecule for treatment of acute vaso-occlusion, and we don't have data on that yet. Next slide. So why is everybody aiming at selectins if they're trying to aim at adhesion? One good reason is because selectins do mediate both red cell adhesion and white cell adhesion and interactions. The second is that even at the beginning, we knew that there were at least some inhibitors of selectins, namely heparins, and they had been studied in animal models of vaso-occlusion and shown to be useful. And there was also a clinical study done, I believe, in Kuwait a number of years ago with a low molecular weight heparin, showing that it also appeared to shorten vaso-occlusive episodes in humans. So that was a good starting point, but obviously people came at it from different directions with different kinds of compounds, as I've said. Next slide. So one could also argue that selectins might not be the best target for therapy. And the reason is that selectins mediate what is called a fast on, fast off kind of interaction. So it mediates what's called cell rolling in small blood vessels, where cells become very transiently tethered to the endothelium and then roll right off. And so they don't mediate firm or kind of permanent adhesion. What happens when selectins do mediate this rolling interaction, however, is that can lead by itself to leukocyte activation and then leukocyte arrest and capturing of erythrocytes. But actually, if you want really firm adhesion, what you need are integrins. But if you activate leukocytes with selectin-mediated adhesion, they will start activating their integrin-mediated adhesion. And so will endothelial cells, which will then lead to interaction with the erythrocyte integrin receptor called ICAM4. In the case of leukocytes, you also get transmigration of leukocytes into tissues. That's not particularly relevant in our context. Next slide. So, so there's been a number of experimental models that have shown that inhibiting selectins improves blood flow in sickle cell mice. And the one that's up on the upper left actually is using heparin in those mice, and 91 is a monoclonal antibody to P-selectin. Heparin binds P-selectin, and both reduce the rolling of red cells on endothelial cells in response to thrombin treatment of endothelial cells, which activates adhesion. So there was a modest effect of heparin in that model, and it was pretty equal to the anti-P-selectin antibody. In the bottom panel, A and B, the A panel counts red cell interactions with white cells that are immobilized on the endothelium. And what you can see is that GMI 1070, now called Rivipansel, reduces that interaction markedly, as do a combination of antibodies to P-selectin and E-selectin. And in the B panel, you see what the result of that is, which is the blood flow increases when you either treat with the drug or treat with the monoclonal antibodies compared to just PBS or phosphate buffered saline. And so I think it's not totally resolved the relative benefits of interfering with P-selectin versus E-selectin. There's still some controversy about that, but from these experiments, it suggests that both are probably valuable. Next slide. So the first molecule I'm going to talk about is GMI 1070, or Rivipansel. As I said, it's a novel small molecule, so it's a small carbohydrate molecule. It inhibits all selectins, but primarily E-selectin. And in preclinical models, such as in the experiment I showed you in the previous slide, it reduced cell adhesion and reduced vaso-occlusion. And so actually in a mouse sickle cell model of induced vaso-occlusion, it improved survival of the mice in that model. And then phase 1 studies supported that it was safe to give both to normal subjects and to those with sickle cell disease. Next slide. So the company that developed this molecule, which is glycomimetics, hence the GMI, put together a prospective, multi-center, randomized, placebo-controlled, and double-blind study of their drug in adult and pediatric patients with acute vaso-occlusion who are admitted to the hospital. And they were given the drug twice a day or placebo twice a day, in addition to the standard of care of the institutions, which varied somewhat from institution to institution. And along the way, they did pharmacokinetic assays as well, clearly as safety assays. The enrollment was completed. I will just note that historically it's been very hard to complete enrollment for sickle cell clinical trials. That's gotten a lot better. But this trial was a little bit exceptional because it actually did successfully complete its planned enrollment in an inpatient study, which is very hard to do. And the primary endpoint in this study was time to resolution of the vaso-occlusive episode, which was defined as a composite endpoint. So it was kind of an either or, not an all of the below endpoint. So either the patient had to have reduction in their pain of 1.5 centimeters on a 10 centimeter scale and transition to only oral analgesics from their intravenous analgesic, opioid analgesics, or readiness for discharge is agreed upon by the doctor or the patient, or actual discharge. And then the secondary endpoints they studied, including length of hospital stay, opioid utilization, that is total opioid utilization, and then the pharmacokinetic and safety profiles. Next slide. So this is a kind of Kaplan-Meier type curve looking at time to resolution of vaso-occlusion as I just defined for you. And so the red is the GMI 1070 treated group, and the black dots is the placebo treated group, with the higher the number being the higher the probability of the VOC being resolved at whatever time point was indicated by the x-axis. And so what you can see is that within about 48 hours, there's a clear separation of those two lines. Everybody gets resolved at the end of the day. That's off this particular graph. But for a good number of days, there's a pretty big separation between how many people are likely to have resolved crisis if they receive the drug versus placebo. Unfortunately, because there is so much variation in time to resolution among patients, with some patients being resolved in 2 days, others being resolved in 7 to 10 days, the p-values for this particular endpoint were not significant, except in a couple of kind of subpopulations. But in general, the p-value was not significant. Next slide. This chart, though, shows you the percent of patients who had resolved the crisis at various time points from 48 to 120 hours. And again, you can see by looking at these numbers that the GMI 1070 did better at every time point. And the length of hospital stay, as shown on the bottom, was quite different, being approximately 2 days different as the mean in hospital stay. And of course, by looking at the mean, you're to some extent getting rid of the outliers, both early and late. But there had been no study before this that had anything better than a couple of hours difference, which arguably is not clinically significant. Whereas if we can get our patients out of the hospital 2 days earlier, I think most doctors would agree and most patients would agree that that is clinically significant. Next slide. Interestingly, this drug did achieve one quite statistically significant endpoint, which is reduction in cumulative IV opioid use. And so this graph shows 24-hour IV opioid use in the placebo patients and the study drug patients. And so even by day one, the amount of opioid use in the first 24 hours after receiving the drug was quite low compared to in the placebo arm. Almost 100% of these patients in both arms were using patient-controlled analgesia, so that the amount of opioid they received was driven by their pushing a button in response to their pain. And so the early decrease in opioid use, I think, not only was statistically significant, but again, clinically significant. And so these are the data that led to the design of the phase 3 study, which in design is fairly similar to the phase 2 study. It's being used in acute vaso-occlusion in hospitalized patients only, for a maximum of 7 days of treatment. And as I say, we don't have any results yet. So I can't really speak any more to that. On the next slide, I'm going to start talking about Crizanlizumab. The first kind of phase 2 study of Crizanlizumab was called SUSTAIN. And again, this is a humanized monoclonal antibody that binds to P-selectin and blocks its interaction with the P-selectin glycoprotein ligand PSGL1, which is expressed by leukocytes. They first did a phase 1 clinical study looking for dose and looking for safety. And then they constructed a phase 2 prophylaxis efficacy study in sickle cell disease, where they gave an IV infusion of the drug once every 4 weeks. Essentially, through week 50, there was placebo controlled, it was double blinded, and it treated patients with basically all types of sickle cell disease, not just homozygous hemoglobin S. Patients were anywhere from 16 to 65 years old. They could be on hydroxyurea. They didn't have to be on hydroxyurea. So they wound up treating patients, some of whom were on it, some of whom were not. And they were required to have had between 2 and 10 vaso-occlusive episodes in a year prior to entering the study. They had to not be on chronic transfusion and not be on anticoagulation because of the interaction of heparin with P-selectin. And their primary outcome was the rate of vaso-occlusive crises in the year of treatment. And this was published, the results were published in 2017. Next slide. They also achieved their total enrollment. They did not only look at placebo versus drug, they looked at 2 doses of Crizanlizumab. And again, they gave 14 doses every 4 weeks. And they enumerated the rate of days hospitalized, the time from first treatment to first hospitalization and to second hospitalization for pain, and the annual rates of uncomplicated crises. Next slide. So here are some of the results that you can see. And so the first set of numbers, so there were 65 to 67 patients in each arm. And as far as the first set of numbers, you can see that if you look at rates of crisis per year, it was almost 3 for the placebo arm. It was 2 for the low dose arm, and it was a little more than 1.5 for the high dose arm. And the p-value between placebo and the high dose arm was statistically significant. And beyond that, 24 of the 67 patients receiving the high dose Crizanlizumab had no crises over the first year, and only 11 patients in the placebo arm experienced that. And the low-dose Crizanlizumab arm was more like placebo in that measure. The baseline rate of crises was similar between those 3 groups. So this was felt to be an important endpoint measuring an effect of the drug. And then below the solid blue line, you'll see the annual rate of days hospitalized. And there was a modest reduction in the median rate, although, again, the statistical significance in this relatively small population was not there. Next slide. So all the results I just presented to you were intention to treat, so they included patients who didn't necessarily get all their doses, or whereas they went back recently and looked to analyze the per protocol population. In other words, those people who totally completed the study and all the treatments, and showed that the number of patients who did not experience VOCs if they got all their treatments was very highly statistically significantly reduced, from 12% to 37.5%. That the median time to a first on treatment vaso-occlusive episode was doubled, again, highly significant, and that the annual rate of vaso-occlusion was about halved, and that was also statistically significant. Next slide. So I think that the time to first crisis was significantly increased. Unfortunately, and for reasons we may not understand, there were no significant measurable changes in quality of life. And they did try to assess this in a number of ways, but could not demonstrate any differences. There were also no significant differences in hemoglobin levels or measures of chronic hemolysis during the study. So it looked like even though vaso-occlusion, the process or the pathophysiology of vaso-occlusion was affected, things like hemoglobin level and hemolysis and quality of life were not affected. Next slide. The adverse events were relatively common, although that's true for just about any sickle cell study, because patients get adverse events essentially whether or not they get drug, they get crises, they get acute chest syndrome, pneumonia, they get fever. And this was true for this study as well, which always makes sickle cell disease studies a challenge because these are sick patients. Next slide. Finally, I want to talk a little bit about heparins in sickle cell disease. Heparins are things we use most frequently or think about most frequently for their anticoagulant effect, but they do have multiple biologic properties, and that includes blockade of P-selectin-mediated adhesion. In addition, heparins bind to other molecules weakly or more weakly to L-selectin, but they bind to von Willebrand factor, to fibronectin, and thrombospondin. They do inhibit red cell adhesion in vitro and in an animal model, and they can restore blood flow in sickle cell animal models. And finally, the low molecular weight heparin tinzaparin, which I mentioned was used in a study in Kuwait, reduced the time to resolution of vaso-occlusive episodes in that single center study that was published in 2007. Next slide. In some of our preclinical work, we looked at the ability of an antibody to P-selectin called 9E1. You saw that before, to reduce adhesive events. That's shown on the left. And then we compared that with the drug Sevuparin on the right. And IL-13 and histamine is what is used to activate endothelial cells in culture to express P-selectin. And then you can measure red cell adhesion events in this instance, and you can see that with Sevuparin at various concentrations, that adhesion is markedly reduced, and likewise with the antibody to P-selectin, the adhesion is significantly reduced. Next slide. So Sevuparin is, as I mentioned before, a chemically modified low molecular weight heparin with almost no anticoagulant activity, and is otherwise very similar in low molecular weight heparin in the way it circulates, its half-life, etc. And it has been developed by a company in Sweden called Dilaforet. Initially, they studied its effect on cell sequestration in severe malaria, but they also thought it might have a use in sickle cell disease. And so they designed and have now conducted a phase 2 study using Sevuparin in acute vaso-occlusion in sickle cell disease. This has mainly been done in the Middle East and in Europe. It has not been done in the United States. And we don't have data on it yet, but I imagine we should have data on it in the coming couple of months since the study is now completed. Next slide. Hopefully it will mimic what we were able to demonstrate in mice, which is shown here. And on the left is a measure of vessel occupancy. This is actually measured under a microscope through something called a window chamber, which lets you look directly at vessels. And you can see in the mice that as you gave more Sevuparin, you got less and less adherent cells along the blood vessels, and these were postcapillary venules. If you then measured blood flow, what you got concomitantly was better blood flow as you gave increasing amounts of Sevuparin to the mice that you had induced vaso-occlusion in. So hopefully this is another drug which will show efficacy in humans. Human red cells aren't exactly like mouse red cells in many respects, and have different adhesion molecule expression. So we don't know until we know, but we're waiting for those results. Next slide. So in conclusion for this part, Sevuparin appears an effective inhibitor of red cell adhesion to endothelial cells in vitro, as well as in mice. And also we have studied and published that it can not only inhibit red cell adhesion to endothelial cells, but it can inhibit human neutrophil adhesion to endothelial cells. So we will await the phase 2 clinical study. Next slide. So getting back to one of our original schematics here, this is where things stand. The anti-selectins are designed to inhibit adhesive interactions. There has been some study of anti-signaling molecules as well, mainly beta blockers and inhibitors of MEK, part of the MAP kinase pathway, and they are effective both in animal models as well as in vitro, but they have have seen very little clinical testing. Beta blockers have been tested in kind of principle in humans, but not for clinical, or for very little clinical effect. It's been a very small study. Anti-inflammatory agents shown in red on the right so far have not been very helpful. The one human study looked at T cell activation and did not show any effect. Anticoagulants and antiplatelet agents have been studied. The low molecular weight heparin study in Kuwait looked like it had an effect that hasn't been repeated, and so far antiplatelet agents have not had clinical effect in sickle cell disease. And finally, on the lower left, hydroxyurea we know is an effective agent in reducing, although not abolishing, vaso-occlusive episodes, acts in part by increasing hemoglobin F and probably the various kinds of red cell damage that occur in sickle red cells. It probably also has other effects, including decreasing leukocyte count and decreasing expression of adhesion molecules in those leukocytes. Next slide. So where are we? I think the best thing is that the sickle cell field is a very active one for pharma companies right now, and a lot of things are being studied. There's active clinical trials, and I think that bodes well for the sickle cell field in general. And things I haven't mentioned actually, but I probably should, is the GBT440 molecule. Actually, if you will reverse the slide, one slide, so I can just point that out. Can you go back one slide? Okay, so thank you. So GBT440 is designed to give red cells what amounts to a little bit of carbon monoxide poisoning. What that does is it shifts the oxygen dissociation curve, makes red cells hold on to oxygen better and thus sickle less. And it produces, in their phase 2 clinical studies, an increase in hemoglobin concentration. So it's a drug like hydroxyurea, which will increase the hemoglobin concentration in patients who receive it. It has not yet been shown to affect, and I don't know if it will be shown to affect vaso-occlusive events, but it does increase hemoglobin. Next slide. So outlook for the future is that we have a very active field right now. And some companies are engaged in trying to prevent vaso-occlusion, in part because this is the quintessential symptom of sickle cell disease and the one that patients deal with the most frequently. But ultimately, there is a belief that if we can prevent vaso-occlusion, including subclinical vaso-occlusion, that we may prevent the gradually increasing organ damage that survivors with sickle cell disease occur as they age. Next slide. We have also, over the past 20 or so years, learned a lot about the pathophysiologic mechanisms of vaso-occlusion, and indeed how a relatively simple mutation that affects a protein only expressed in red cells can engender widespread effects that we observe in patients with stroke and pulmonary hypertension and renal failure and bone avascular necrosis and many other effects. And so as we've learned about the pathophysiologic mechanisms of all these effects, we have made drug therapy targeting them much more feasible, although in some senses we suffer from the fact that we've discovered a very complicated pathophysiology. And so what we may be heading into is actually an era of multi-modality therapy, where we will ultimately prescribe for a patient, for example, hydroxyurea plus a drug specifically targeted to adhesion, plus a drug specifically targeted to reducing hemolysis, and perhaps even another drug that is an anti-inflammatory drug. And I think that's what the short-term future holds. Long-term, of course, everybody wants to figure out how to cure it, and we can do that with bone marrow transplant and potentially with gene therapy. But I think making that available to the majority of patients is a very long way off. In the meantime, blockade of selectin-mediated adhesive events is probably the most promising current therapeutic approach that is closest to seeing clinical availability. And so I think it's important to understand why that approach is being used and how it works. Next slide. And this is just a list of the many people that have helped me work on this problem, including the people from pharmaceutical companies that I work closely with in developing the Rivipansel or GMI 1070 drug and the Sevuparin drug when I was involved in those early studies. And of course, none of this can happen unless our patients are willing to participate, sometimes just to give blood that we can study, and sometimes to participate in drug trials to be able to prove whether these drugs work or not. And so I think we have to thank them as well. Thank you.
Thank you so very much, Marilyn. What an excellent talk. It is so exciting to learn about these therapies that can improve the lives of women and girls and all patients with sickle cell disease. Now, historically, we've only had one disease-modifying therapy, hydroxyurea, and now, as you've alluded to and almost promised us, there's many other therapies on the horizon. While others collect their thoughts and perhaps submit their questions, I have a couple related to reproductive implications, particularly around pregnancy. I I look at these drugs targeting selectin-mediated adhesion, and I hear that Rivipansel is a small molecule, so I can't imagine that that would ever be a good therapy in pregnancy, as we'd expect it to cross the placenta. I see that the molecular weight is about 1,500 Daltons or something, and below the threshold of where a molecule would cross the placenta. But Crizanlizumab is an antibody. We wouldn't expect that to cross the placenta. And Sevuparin's a low molecular weight heparin, which also has a high molecular weight, doesn't cross the placenta, and we use low molecular weight heparins in pregnancy. Any thoughts about transplacental passage and possible use of these medications in pregnancy?
Well, I mean, I think when it comes to heparins, you undoubtedly know more about them than I do in the context of pregnancy. What I wonder about, and don't know the answer to, is whether selectins or some of the other targets of heparin actually, how important they are to the development of the placenta and the interaction of the placenta with the uterus, and I don't know the answer to that, you know, because clearly, for example, laminin, and especially the laminin specifically that sickle cells bind to, is laminins 10 and 11, and they are actually, I know because that's where they're isolated from, are isolated from umbilical veins. That's where you can extract the most of that particular kind of laminin. So, you know, whether or not these drugs are okay to use at various stages of pregnancy because of their interaction or their interference with various kinds of cell adhesion, mediated potentially not just by selectin but by other things. You know, if you're talking about heparinoids, if you're talking about Crizanlizumab, which is a very specific P-selectin antibody, I guess you only have to worry about whether P-selectin is important in the placenta.
Oh, well, thank you for those thoughts. Very interesting. Like, we know how important that integrins and adhesion molecules are in normal implantation, so there could be implications there. But we do have a lot of safety data for low molecular weight heparin.
Right.
Now, based on the fact that people with sickle cell disease are at increased risk for venous thromboembolism and arterial thromboembolism, why eliminate the anticoagulation properties of a molecule that's used for treatment of vaso-occlusive crisis?
Well, I think there's potentially several reasons. The company that developed Sevuparin, and they're not the only ones who've developed molecules like this. There's some people in, I think in the Emirates, that also have developed some similar heparinoid molecules. They were thinking originally about malaria and trying to interfere with cell sequestration that you see in severe malaria and cerebral malaria. So they were really only interested in the adhesive aspects. But I must admit, in sickle cell disease, a lot of people worry, and especially adult docs worry about the tendency for intracerebral hemorrhage and hemorrhagic strokes in patients with sickle cell disease. And so we had a very long time ago proposed a study to the NIH of anticoagulation and in sickle cell disease, and there was a lot of pushback because they thought that everybody should have like MRIs and MRAs before they were given something like heparin. You know, that's, I mean, we clearly do MRIs and MRAs in some patients who have headaches and things like that, or stroke. But on the other hand, we treat thrombosis in sickle cell patients with heparin or other similar molecules without first doing MRIs and MRAs on everybody to make sure they don't have moya. But clearly the risk of cerebral hemorrhage in sickle cell patients who are anticoagulated, I think, is higher than in the general population.
Thank you. I wonder if there'd be less pushback now that there's been increasing recognition of the high risk of venous thromboembolism, or the higher risk of venous thromboembolism.
There might be, because that, when we tried to do that, it could be 15 years ago. It was a long time ago.
We have a question from the audience, and that is, this is from Cheryl Mensa. Will there be, do you expect that there will be combination therapy with hydroxyurea and DARA and the new selectin molecules in the future?
I think my answer to that is definitely. First of all, there is essentially no study being done that I'm aware of any drug for sickle cell disease that will exclude patients who are already on hydroxyurea. It's a given that whatever we do has to work in the context of patients taking hydroxyurea. And part of that is because hydroxyurea not only treats symptoms, it prolongs life. And that is pretty well proven. And so no one's going to say you have to stop taking hydroxyurea so that we can try some drug that we don't know whether it works or not. So I think to that extent, we're going to have, you know, multi-modality therapy. And then I think because the pathophysiology of the disease is really so complex that it makes sense that for non-curative therapy to actually target multiple pathways. And I think really a good example of this is how we treat coronary artery syndromes, because we don't treat coronary artery disease with one thing. You know, they may get a statin and a beta blocker and an antiplatelet agent and maybe a couple of other things I'm not thinking about right now, but they get, you know, they target all the things that the cardiologists know go wrong in atherosclerotic disease. And I think that's what we're going to wind up doing in sickle cell disease as well. And in fact, we, myself with Greg Versalati and Poonam Malik, just kind of published a review of this in the Nature Reviews series, Nature Reviews Drug Development, and making the argument that this is the future for sickle cell disease is multimodality therapy.
Well, thank you for that amazing presentation, your insights, your speculations. It's wonderful. Thank you for answering the questions. For our audience, as a reminder, you'll be able to review this webinar in the future or share today's proceedings with your colleagues by visiting fwgbd.org and accessing this webinar under the archived webinars section. For those of you who may have additional questions on this material following today's program, we encourage you to visit our Ask the Experts feature on our website and submit your question online. And in conclusion, thank you, Dr. Tellen, and thank all of our attendees today. We look forward to your future participation in Foundation programs.
And thank you for letting me participate.
Oh, it was our honor. Thank you, and thanks to everyone. Signing off.